Thanks everyone for coming today. Dawn, it's always nice to hear it from a different perspective. I think you laid the stage very well. So when we were writing the guidance document or the consensus, we realized that we didn't have any information on IVL, and that prompted us actually to go back. And as Dawn mentioned, we looked at and presented the 30-day data. So it was just a really good, platform and impetus to do that. And today we have a poster looking at the one-year results, and I'm going to show those here. So just by way of background, I think Dawn mentioned this, but after stent implantation, even long-term, this is out to 3 years, female patients with moderate to severe calcification have much worse outcomes in terms of mortality rates are increased, death and MI and revascularization rates are increased anywhere from 38 to 56%. So this is a very high-risk cohort of patients. As mentioned again, rotational atherectomy and some of the standard therapies for plaque modification in female patients are associated with worse outcomes, procedural outcomes. Not to say that they shouldn't be used, but we need to recognize that we have a lot more coronary dissections, tamponade, bleeding complications, etc. Our females are not really doing very well with current therapies. So this is the data we showed at TCT last year at 30 days. This is a pooled patient level analysis, close to 600 patients, looking at the procedural outcomes of intravascular lithotripsy in our female patients. So procedural outcomes, you can see men versus women are similar, and that is new. We haven't seen this in this patient population. I have to say, I'm not going into the details here, but these are truly severely calcified lesions. And comparing that to some of the atherectomy trials, you can see that in terms of dissections, perforations, and other complications, we didn't see that in the IVL series compared to atherectomy. So let me now present to you the one-year outcomes. What we wanted to do coming out of TCT is really look at whether these results are sustained out to 1 year. And what this is again, patient-level pooled analysis of CAD 3, 384 patients, and CAD 4, 64 patients. That was done in Japan. You can see 5 countries and 55 sites representing 450 patients. Once again, 25% female patient representation. That's what it is. In terms of the poolability of these studies, all the trial design, endpoint, adjudication, follow-up, core laboratories, etc., were all very consistent. The endpoints were consistent. So I think, it really justifies pooling these data together. Just wanted to point out here the peri-procedural MI definitions here, CKMB greater than 3 times upper limit of normal. And again, this was done across the board in both studies. And the definitions of calcification, again, very, very consistent. So here we are, 448 patients, 106 females, 342 males. Excellent follow-up, so 98% follow-up rate at 1 year in both men and women. So just very briefly to go over some of the patient characteristics here. As expected, we have our women are slightly older, had less smoking, but otherwise, in terms of hypertension, diabetes, etc., were very well balanced between men and women. The angiographic characteristics here, again, no surprise, you see smaller vessels. We always see that. And in terms of the lesion characteristics, again, very diffuse disease for both men and women, slightly shorter, I guess, in the female patients in terms of lesion length and calcified length. So this was, again, measured by the core laboratory, but 44 millimeters in women, 49 in men in terms of calcium length, and severe calcification in 100% of patients. So again, really high-risk cohort. The procedural characteristics, just to show some of the differences, procedural time was less in our female patients. There were fewer IVL catheters being used in female patients, and the number of pulses were slightly lower in women compared to men, but otherwise everything was pretty well matched in terms of post-dilation, number of stents, etc. And interestingly, more femoral access compared to radial access, not significant, but clearly trending. Looking at the outcomes in this series in terms of diameter stenosis, controlling for the differences in vessel size were very well matched. So pre-procedure, post-IVL, about 35% residual stenosis, and post-stent implantation, excellent results of about 10% residual stenosis. The differences in acute gain and MLD there are really driven by the fact that male patients have bigger vessel sizes. All right, so this is coming to the, again, the angiographic complications and dissection rates. Once again, we're seeing very low complications, severe dissections in a DNF in a very low number of patients, and less actually in our female patients than the male patients. Post-stent implantation, of course, no complications whatsoever. Here again, procedural success was similar between men and women. 30-day outcomes, completely similar. Again, no significant differences here. And here we are tracking out to 1 year. And you can see that major adverse cardiac events here was absolutely similar between men and women. Again, we have not seen this previously in all the other series. We tend to see the outcomes in female patients being much higher than male patients. And you can see all the components here of major adverse cardiac events. This is target lesion failure at 1 year. Again, consistent results, so excellent outcomes for our female patients. And the components of TLF, I think it's noteworthy, but numerically at least, lower rates of ischemia-driven target lesion vascularization and no stent thrombosis in our female patients here. So again, I think really outstanding results. So, what does this tell us? Essentially, from the CAD 3 and 4 pooled analysis, clearly the largest series that we have safe and effective results at 30 days, at 12 months. And again, I think the panel, there'll be a great panel discussion, but I think putting this in context of atherectomy and the results in those patient populations, I think that definitely represents a safer modality when it can be used. So thank you very much for your attention.